professionals, my name is Donna Edwards, and I'm going to provide you with some continuing education units so that you can continue to work in your profession with some enhanced knowledge. I am a certified addiction treatment counselor number 4 who is accredited by the Addiction Counselor Certification Board of California. I have worked in this profession for over 20 years. I am a CEU provider approved by CADI, California Addiction and Drug Educators. Treating co-occurring disorders, promoting long-term stability, relapse prevention, and symptoms management. Promoting long-term stability and relapse prevention and symptoms management. Many clients in multifarious caseloads have disorders whose symptoms persist because the medication never totally controls them. Thus, clients need treatment intervention strategies called relapse prevention or symptom management too, to help them maintain abstinence from AOD and manage long-term psychiatric symptoms. Based on clients' level of recovery and treatment participation, psychoeducation, skill training, different than clients who are still using substance or in denial of MH disorders. Treatment is divided in 3 clusters. Cluster 1, intervention for pre-recovery and anti-treatment clients. Clients do not believe they have a problem, forced to treatment, which is mandated by courts or authority organizations or family. The goal of intervention is to promote acknowledgement of both SA and MHD, developing enough motivation to engage with treatment, establishing abstinence, low demand on psychoeducational group to inform nature of treatment and its effects of both disorders, building skills such as participation in treatment program, accepting and receiving feedback, changing behavior, providing hope for a better life. This is as much as rehabilitation process as a rehabilitation process for many clients in this cluster. The length of treatment will vary from client to client. The second cluster is intervention for early recovery and treatment engagement clients. Clients are psychologically in treatment and voluntarily, even they have been mandated, if they've been mandated. They have personally identified and acknowledged having an SA or MH disorder or both. The goals of intervention is psychoeducation and skill training to promote necessary knowledge and skills to manage SA and MD disorders effectively to begin a recovery lifestyle. The length of treatment depends on impairment levels of functioning and skills that clients already possess. This phase associates with traditional relapse prevention and symptoms management activities. In the third cluster, intervention for early recovery and treatment engaged clients, the intervention in this phase focuses on 5 primary areas: teaching common triggers, pressures, and stressors that can cause substance use or psychiatric relapse, early symptoms identification, coping response to triggers, pressures, stressors, or an increase in symptoms, preparing for unexpected events, acknowledging and celebrating self-efficacy. Treatment is mostly within psychoeducational group setting, but can be other treatment modalities as well. Cluster 2, intervention for early recovery, substance abuse management model. This is a model that focuses on the most common problems encountered in recovery for individuals with schizophrenia and alcohol disorders and offers detailed behavioral solutions for each. The dialectic behavior therapy. This model is for individuals with borderline personality disorder. Participants' mindfulness skills, interpersonal affective skills, emotional regulation, and distress tolerance. An example of relapse prevention curriculum for more impaired individuals with co-occurring disorders, MH and SA recovery models, overview of relapse prevention skills, warning signs and triggers, defense mechanisms, cognitive distorted and self-defeating attitudes, emotional management, anger management, stress management, planning and problem solving, communication and assertiveness, relationships, nutrition and health. Cluster 3, intervention for later recovery and minimal or post-treatment clients. Clients have been in recovery for at least a year, but not normally longer. Clients are in minimal treatment, such as seeing a therapist once or twice a month and seeing a doctor every 2 to 3 months for medication. Clients have fully acknowledged their both SA and MH disorders. Clients might come back to recovery due to crisis life events, participating events, to seek more help, and for repulse prevention. The goal of this phase is continuing psychoeducational approach to inform and build skills for lifelong, long-term stability and ensuring increase for symptoms management and stability, and at the same time to empower them by reminding them the skills and strengths they already have gained to stay in recovery and overcome many obstacles. Promoting long-term stability, relapse preventions, and symptoms management. When knowledge and skills do not work, relapse are common to in phase of treatment. View relapse as an opportunity. Assess relapse immediately to find out the cause trigger. Develop appropriate treatment plan phase based on assessment results. And reassess. I want to